A very good morning to one and all. Today we'll discuss about second part of pulp and periapical disease. In this lecture, we will learn about the sequelae of pulpitis, what is apical periodontitis, what is acute and chronic periapical abscess, what is periapical granuloma, periapical cyst, what is conversing osteitis, phoenix abscess, and thus we will be concluding this topic. Our learning objectives for this topic will be sequelae of pulpitis, apical periodontitis, acute and chronic periapical abscess, periapical granuloma and periapical cyst, conversing osteitis, and phoenix abscess. So to start, as we can see here, this is the flow chart showing the sequelae of pulpitis. In the last lecture, we had known what is pulpitis, how the pulpitis occurs, and what are the different causes of pulpitis. We have discussed under the physical, chemical, and bacterial causes, the different causes of pulpitis. We have also discussed what is reversible pulpitis and what is irreversible pulpitis. In this lecture, we will discuss about what is the periapical changes. So as you can see in this flow chart, the damage to the pulp leads to pulpitis. It can be either reversible or irreversible. Once the pulp is totally damaged, the infection reaches in the periapical region. The first, there is inflammation in the periodontal ligament space, that is called as apical periodontitis. From here, if it takes an acute course, it can lead to the acute periapical abscess, leading to again osteomyelitis, periostitis, and cellulitis. If it takes a chronic course, it can lead to the chronic periapical granuloma, periapical cyst, or the abscess, and thus leading to again osteomyelitis, periostitis, and lastly to cellulitis. So this is the sequelae of pulpitis. Coming to the first periapical region, that is the acute apical periodontitis. It is the inflammation of the periodontal ligament space. The symptoms are tooth is extruded, tooth may be painful on closure, and tooth is tender on percussion. This tender on percussion is the classical sign of a acute apical periodontitis because the infection is in the periapical region. As we can see here, this is a picture, a diagrammatic picture showing the hyperemia in the periodontal ligament space here. So there is the inflammation from the pulp, there is loss of the enamel dentine, and infection has gone into the pulp. From the pulp, the inflammation has gone into the periodontal ligament space, and thus there is a inflammatory signs we can see in the periodontal ligament space. So if you take a radiograph of this tooth, we can see there is a widening or thickening of this periodontal ligament space here, which is shown as the thickening of this black periodontal ligament space here. So if you take in the investigation, if you take radiograph, we see a thickening or widening of the periodontal ligament space. Treatment: if the tooth is vital, that is if it is because of TFO or because of high points, it can lead to the then we can go for to relieve the symptom. We can remove the high points. We can remove any trauma. If the tooth is non-vital, if there is pulp is totally damaged, then we will go for the RCT. So next is acute periapical abscess. It suggests infection into the periradicular bone. It is a localized collection of pus in alveolar bone at apex of the tooth following death of a pulp. So as we can see here in this picture, there is the enamel, dentine, and the pulp. Pulp is totally damaged, and from inflammation or infection from the pulp has gone to the periradicular region. There is a localized collection of pus in the periradicular region. This is called the abscess. So this is a classical picture of the acute periapical abscess. Clinical features are: there will be severe, continuous, or throbbing pain. There will be extraoral swelling with inflamed skin. There will be local rise in temperature. There will be vestibular obliteration, and tooth will be tender on percussion. So we can see all signs of the acute inflammation. Coming to radiographic features, we can see a large carious lesion with pulpal exposure because the inflammation has gone from the pulp. There will be defective restoration, that is any cause which can lead to the inflammation in the periradicular area. There will be widening of the pedal space. There will be loss, there will be discontinuity of the lamina dura in the acute periapical abscess cases. Treatment will be RCT because the pulp is totally damaged and the infection has gone into the periradicular region. So the treatment will be root canal treatment. Then next is chronic periapical abscess. It is a long-standing low-grade infection of periapical tissue. Clinical features will be mostly it will be asymptomatic. Patient will not give any history of pain. There will be caries with pulp involvement, obviously. Then there will be sinus opening, pus discharge, or paralysis formation. This sinus opening or pus discharge or paralysis is the classical sign of a chronic case. In any case, if we see a tooth with a grossly decayed tooth with the sinus opening in extraorally or intraorally, it is a case of the chronic periapical abscess. If we take a radiograph of this same lesion, we can see a diffuse rarefaction or radiolucency at the apex of that affected tooth with loss of lamina dura. Treatment will be again either RCT if the tooth can be saved, if the corneal structure is it can be saved, then RCT, or if it is totally grossly decayed, then we can go for the extraction. There is a phoenix abscess. The phoenix word has come from an imaginary bird, which is said to arise from nowhere. So this abscess signifies an acute exacerbation of a chronic lesion. Means a lesion was there before, but it has subsided, and again it has come from nowhere. So clinical features are acute symptoms that we can see now. Diagnosis will be history of previous swelling and the pain. Patient will tell that I had previous swelling and pain, but it has subsided. That may be because of the drug, or that may be because of the increase in the immunity. And now because of the decrease in the immunity or increase in virulence of the pathogenic of bacteria. So again, the lesion has reoccurred. So this is the cause of this is the case of a phoenix abscess. Treatment will be again antibiotics and analgesics followed by the RCT. Then is periapical granuloma. The cause is the chronic low-grade defensive reaction of alveolar bone to irritation from the root canal infection. Clinical features are it is seen in young age group patients. Patient will have deep caries and it will be asymptomatic. It will be non-tender on the percussion. Then is how do we diagnose this? So there will be a normally there is no pain, so it will be diagnosed mostly on the radiographic examination, and tooth will be non-vital. So if we take radiograph of the affected tooth, we can see there is a well-defined rarefaction at the apex, which is less than 1.6 centimeter in diameter. So if it is a well-defined lesion, well-defined relucent lesion at the periapex of a tooth, and tooth is non-vital, it is a case of periapical granuloma. Treatment again will be RCT or root canal treatment. Then is periapical cyst. It occurs mostly in maxillary incisors because the maxillary incisors are the most common tooth to undergo trauma, and it is related with the non-vital tooth with non-tender percussion. It can, in large cases, there can be expansion of the cortical plate, as you can see in this picture, and which can also lead to displacement or resorption of the tooth. In this picture, you can see swellings secondary to the bony expansion of the cortical plates. So what is the pathogenesis? Once there is periradicular inflammatory changes, it causes the epithelium to proliferate. As the epithelium grows into a mass, the center loses the source of nutrition, and therefore there is necrosis in the center. And this necrosis leads to the formation of a cystic cavity, and this cystic cavity later enlarges to form a cyst. So how do we diagnose? Clinically, we can see a swelling and the tooth will be non-vital. Once we take a radiograph, we can see a well-defined radiolucency at the periapex of the lesion, and there will be also resorption of the roots or the displacement of the roots and bony expansion. We can see a well-defined rarefaction with cortication cortication. We can see a well-defined rarefaction with the cortication. The size will be more than 1.6 centimeters. Treatment will be enucleation or marsupialization. If the cystic lesion is smaller in size, the treatment is enucleation followed by RCT. Sorry, RCT followed by enucleation. And if it is larger in size, we can go for marsupialization. The next lesion is conversing osteitis. It is a response to a low-grade chronic inflammation of periradicular area. It is usually asymptomatic. Affected tooth is non-vital. Radiographically, it appears as a localized area of radiopacity surrounding the affected root. We can see here, this is the case of a chronic lesion where there is a caries involving the pulp, but this this infection is not acting as a it's not leading to bone loss, but it is acting as a stimulus for bone to form. So it will be seen mostly in the case of the young adults where there is low grade infection. Treatment again will be RCT because the infection has gone into the periapical region. So it will be treated by root canal treatment. So to conclude, injury to the pulp lead to the inflammation called as pulpitis, which can be either reversible or irreversible. If untreated, it leads to the sequel of infection in periapical region and into alveolar bone. So timely diagnosis and intervention is the key to management for such cases. So by going through this lecture, we should be able to answer what is the sequelae of pulpitis, what is the periapical abscess and acute periapical abscess and chronic periapical abscess, and now we also know what is phoenix abscess. So be able to answer these questions. I hope this lecture was useful. Thank you so much.